Morning, everyone.
Good morning.
Good morning.
Good morning.
You know, it's kind of entertaining watching everyone just move around and get stuff and oh yeah, I got to get this, I got to get that. And
Did you see my husband walk by? So then go find some place to be.
that's why I keep my camera off.
Good morning.
Good morning. All right, we got about a minute to go and then we'll get going. Good morning, Commissioner Lindy.
Hey, good morning, Commissioner Anderson. Good morning, everyone.
Morning. Good morning, Commissioner McKinney.
Good morning, everyone. Happy Wednesday.
Morning.
Morning.
Morning. Thank you.
All right, it's 8:30. We will go ahead and start. I will open the meeting and call the meeting to order. One note, Ms. Duval will be joining us about 9:30, I've been told. So if you would, Mr. Ibach, would you please call roll?
Okay. Commissioner Anderson.
Here.
Dr. Cleary.
He's there, but it's on mute.
Dr. Cleary, I think you're on mute. All right, Dr. Cleary is here. Commissioner McKinney.
Present.
Commissioner Lindy.
Here.
Councilmember Byers.
Here, thank you.
Dr. Atterbury.
He's not on the meeting yet.
Okay, Dr. Atterbury is not on yet. Okay. And then Nyla will be late. Jackman Health District staff, Andre Fresco.
Here. Good morning.
Myself, Ryan Ibach, Chase Porter,
Morning.
Melissa Sixberry,
Here.
Lillian Bravo,
Here, good morning.
John McGee,
Here. Good morning.
Nathan Johnson,
Here.
Dr. Bard,
Morning here.
Jocelyn Castillo, Victoria Reyes,
Here.
James Elliott,
Good morning.
Kim Wakeman.
Good morning.
Okay, and we do have one, let's see, is Dr. Atterbury on yet? Doesn't look like it.
No.
Okay, And then we do have one staff member to introduce. So Chase, would you like to introduce our new staff member?
Yeah, be happy to. We have a new HR specialist with us. Her name is Kim Wakeman. Kim, do you mind introducing yourself?
Oh, I'd love to. Thank you. So my name is Kim Wakeman. I've lived in Yakima for about 12 years. Love it here. I've got over 10 years of HR experience, specifically in areas that I feel make a difference in the community. So I really enjoy working in organizations that make a difference. So I've got HR experience in healthcare and home care and things like that. I'm very excited to be here and help out in this area.
Yeah, and a plus is that Kim has some workday experience. So that wasn't a completely new thing for her. So we're very happy to have her here. Very excited for her to get fully on board. She's only been here like a week now. So we're happy for her to be here.
Welcome, Kim.
Welcome, Kim. When I saw your name there, I thought at first it was KIMA-TV tuning in.
When I saw it, I thought that too.
All right. Well, welcome aboard, and we'll move on. If Mr. Eibach, is there any public written comments?
There are no public written comments.
Okay. We'll move on to the consent agenda. The consent agenda is to be, all the items are listed are to be considered routine by the health board and will be enacted in one motion. There'll be no separate discussion unless one of the board members requests it. The items are March 30, 2022 Yakima Health District Board of Health meeting minutes and payment of accounts payable and payroll issued March 2022 in the amount of $1,727,104.27. Is there a motion?
I move to accept the consent agenda as presented.
Is there a second?
Second that.
It's been moved and seconded to accept the consent agenda as presented. Any comments? Hearing none. All those in favor?
Aye.
Yes.
Aye.
Aye.
Any opposed? Motion passes. Thank you. We'll move on now to the Health District Spotlight Supplemental Nutrition Assistance Program education by Lillian. Lillian, please present.
Thank you. So good morning, everyone. So as the long name suggests, we will be learning about two different programs today. Again, the Supplemental Nutrition Assistance Program in Education, or SNAP-Ed, as well as a new program that we have here at the Health District of Building Resilient and Inclusive Communities, also known as BRIC. So today, what I'll be starting with is giving, on this next slide, I'll be starting with what the program is, a little bit more about what the strategies are utilized, just to get to level set on some of the different programming. And then we'll go into some specific examples of the work that we've done here at the Health District over the last 10 years, talk about some current work, and then I'll be happy to answer any questions. So on the next slide, what we'll review is, again, what is SNAP-Ed? So we'll start with that first program. So the program itself has been with the Health District for over 12 years. It's staffed by Jessica Van Doren, our community health specialist here at the Health District. And the program has grown. 5 years ago, we received about $30,000 a year. And currently we are receiving $100,000 a year for this program. So SNAP-Ed is a program that we receive funding for through the consolidated contract with the Washington State Department of Health. But at the federal level, it is funded by the United States Department of Agriculture. The program, as listed here, utilizes three different strategies, ultimately to support healthy eating and safe physical activity for the SNAP-Ed eligible population. So those that are SNAP-Ed eligible must be have an income of at or below the 200% of the federal poverty line. So that, again, being people of lower socioeconomic status. So when we develop our programming, we do have to demonstrate that our programming is being received by those that are SNAP-Ed eligible, which, again, given the community and the demographic that we serve, it is the majority of our community. So when we talk about these different strategies, the first being direct education, that can be things such as providing nutrition education and food demonstration. The second strategy, health promotion, could be things such as promoting promoting healthy habits via social marketing or other communication methods. And then the third, which I'll go into in a little bit more depth, is something referred to as policy, systems, and environment, which, as it sounds, is initiatives to change entire systems and environments. On the next slide, we'll, as I mentioned, going into a little bit more in depth of what policy, systems, and environment might entail. And really, in its most basic form, policy, systems, and environment, or PSC work, is work that has the goal of making the healthy choice the easy choice. So work in this arena is meant to ultimately modify environments to make healthy choices practical and available to community members. So a few examples of a policy change relevant to the SNAPbed work would be things such as adding a tax to marijuana, make it less accessible, and to fund prevention efforts, working with community coalitions to establish healthy food options in vending machines or in public places, or even changing local ordinances so that corner markets can display produce outdoors. So those are just examples of something that would be considered a policy change relevant to SNAPbed. When we talk about system changes, this is things that are really shifting the way that an organization is solving a problem. So for example, changing the system in which a food bank distributes and procures their food. When we talk about environmental changes, this can be things that are directly changing the physical surroundings. That could be, for example, installing wayfinding signage to promote the use of walking and biking pathways, or even just increasing the number of bike trails itself. So on the next slide, now that we've learned a little bit more about what the different strategies are within the SNAPbed program specifically, here are I'll go over a couple different examples of some of the work that's been done at the health district over the last several years. From 2008 to 2012, the health district actually partnered with Yakima Valley Farm Workers Clinic and the Northwest Centers for Action to provide direct education via after-school programs throughout the Lower Valley. And in these direct education classes, it was essentially nutrition classes and helping students do food demonstrations so that they can learn how to make easy recipes while also learning about some healthy food nutrition habits. Through that partnership, there was also some work that was done through the Rev It Up Community Coalition, and that also worked with schools to improve nutrition policies to offer healthier food and snack options for the students. So a fun fact that I'll share with everyone, because I just realized it yesterday, through my practicum, through my MPH program, I actually volunteered as part of this program itself in 2012. So I thought that was really fun to, 5 years after I've been working here, to realize that that was my practicum through the SNAPbed program. And when we moved on to 2015 to 2017, the Yakima Health District worked with the Yakima Valley Council of Governments, or YVCOG, to work with cities and schools to promote complete streets to encourage healthier communities. And with complete streets, you're working to establish ordinances and policies to allow people to get around safely, increasing safe sidewalk, crosswalks, and signage. And typically, a lot of these different initiatives involved increasing some sort of sidewalks around schools specifically, again, to allow students to get to school and be able to walk to school in a safe manner. During this time, we also collaborated with Fiesta Foods and the OIC Food Bank to implement food demonstrations with healthier food items. So calling out specific healthy foods at the grocery store so that people would understand that they're nutritious. Also providing recipe cards and displaying different nudges or signage to increase fruit and vegetable consumption. When we worked with the OIC Food Bank, we also provided technical assistance so that they could transition from a client choice, so that they could transition to a client choice shopping model. And that's really moving away from the pre-box distribution where people would essentially get a box of food and what they got is what they got, versus moving towards this different client choice shopping model where people would come into the food bank and choose what food that they would like to take. That again improves client satisfaction and also ensures that less food gets wasted.
Lillian, pardon me, and Commissioner Anderson, I'd like to recognize that Commissioner McKinney had a question.
Oh, I apologize.
Yep, sorry.
Thank you. No problem. I don't know how far you were going to go, so if you are going to touch on this, and I'll defer. But you mentioned capital projects, including sidewalks, and I'm just wondering. I know that recently the city of Yakima, was speaking about their bike plan and not having the ability to implement that on the scope and scale that they were hoping to on that timeline. And I'm wondering if this somehow is something that would be, if the funds are usable also for capital projects involving bike lanes, and also if that could parlay into the greenways goals to kind of really connect for commuting. And then I just wanted to make a comment on the last thing you just mentioned, is that a lot of our food banks are actually going towards this shopper method, where people can go in and choose what they would like to have versus getting a box full of things that there might be allergies or food aversions or things like that. So I think it's a great way where people can take pride in going down and shopping just as you were shopping down the aisle. So love to hear that. But just curious about integrating with the Greenway and the city for bike paths, things of that nature.
Yeah, absolutely. So I will go into some of the work that we've been doing, but in terms of your specific question, there's definitely opportunity for us to assist in some of that work. In terms of capital purchases with this newer grant, we do have a limited amount of funding that could potentially assist. And so I think some of your questions might be answered as I go further on. And if you have additional questions or additional connections that we can make, absolutely, we'd love to connect on that. Thank you. And let's see. Yeah, so moving on to our current work, again, we are still working on primarily on what we reference policy systems and environment and health promotion. So right now, as I'll be talking a little bit more in depth, we're working with different community-based organizations, coalitions, including the Yakima Bikes and Walks, actually. That is Jessica Van Doren that's participating in those groups at this time. Also with the different schools. And again, just working to encourage the community to use local hiking trails, greenways, and pathways. And so I'll just skip ahead so we can get to that part of it. So on slide 6, where we can actually fund some projects would be within the Building Resilient Inclusive Community. So again, BRIC. So we have received funding through the Department of Health. It's $25,000, but it is something that we can utilize in tandem with the work that's being done with SnapBed. And so again, that work is to support environmental improvements specifically. So on the next slide, I'll get into some of the specific projects that we have been able to fund that we will be able to fund with this grant. And the first being the Heritage Connectivity Trail. The Heritage Connectivity Trail is a multi-agency partnership effort. This work actually started through a planning grant that was received by the Yakima Nation through the National Park Service. And so this work was started because of the clear need to eliminate serious injury and fatal collisions between pedestrians and motor vehicles, specifically along Highway 97. So in the past 10 years, there's been 350 pedestrians that have been injured in collisions and 22 that have died along Highway 97 between Union Gap. And so the purpose of this particular initiative is to bring together, there's about 20 different partners that are working together on this initiative. Ultimately, the trail would span 150 miles between Union Gap and White Swan. But while this project is developing, we were able to fund specifically the communication efforts for the Heritage Connectivity Trail. Of course, there's going to be a lot more funding that's going to be needed to get this accomplished, but we will be able to provide funding for them to work to develop more communication around the initiative and to garner further support. On the next slide, another initiative that we've been able to fund with this BRIC funding is through the William O. Douglas Trail Foundation. So this foundation requested BRIC funds for a licensed bridge and structural engineer to design the decking and fencing for the Natchez River multimodal bridge that's off of 6th Avenue in Northeast Yakima. So the funding that requested was specifically for the engineer to take a look, but ultimately they would like to redesign the trolley bridge to increase access to residents in Northeast Yakima and students that attend Stanton Academy in Davis. Specifically because the foundation has plans to revive efforts to provide hands-on learning in this outdoor setting to the students of Stanton and Davis as they have previously. It's been a good opportunity for them to learn about historical facts on the trail, of course, science, sustaining nature, and ultimately the reason that's getting the funding is to promote physical activity. And then on the last slide, we've also worked with the Yakima Greenway. So we've been working with the Yakima Greenway to evaluate and assess the trails and in terms of how it can be improved. And we actually also did some surveys of community members in terms of what would encourage them to use the trails more. So the results of this assessment was shared with the Yakima Greenways board, and they are using those for further strategy and for further grant opportunities. So the way that we'll be working with the Greenway specifically is because they requested funds to also purchase new shade structure and usable picnic tables. So while the funding itself is limited, it is something that we can utilize to fund some other broader initiatives and efforts.
Thank you.
Oh, and then next slide. Again, just to wrap it up, the current work with our SNAP and BRIC funds is again focusing on enhancing environments and ultimately increasing access to physical activity at this point in time. So through the work in SNAPbed, we've been able to work with many of our different partners, and again to see how public health is uniquely equipped with the ability to not just work on specific initiatives, but to see how we can be a natural partner to government, to nonprofits, and other community members. What we've been able to do with the program is to assess and evaluate the issue, and of course, look broadly across the community and connect different initiatives together, ultimately to improve the health of our community. And with that, I'll conclude to see if there's any questions. And Commissioner, I'm not sure if that was able to answer your question in terms of how we can work together with the Greenway and other communities.
Thank you. I think you did. I think it's great. I wish it was more than 25,000. There's a lot of a lot of need, but that heritage connectivity is a great project.
Are there any further questions or comments for Lillian?
I just wanted to thank Lillian because it was a very good presentation, and I was also aware of the Heritage Project and the great need for that. So I appreciate some of the funds going toward that.
And I appreciate too that there's this larger issue, and I won't say issue, but a mission of getting trails throughout the valley, walking trails in various areas that are not accessible right now in that realm. So continue the work, and we'll have some good trail systems coming up. Next up, we'll have Mr.
Chairman, because I say to Lillian, I also really appreciate all the efforts, particularly for the outdoor activities. As far as the SNAP program, I just have a question about what the demographics are of who actually qualifies for SNAP versus who's getting educated. And my biggest concern is the number of elderly who are living off of Social Security, who definitely qualify for the SNAP program, but never access it and don't really obtain the information on health education, on healthy foods that are available to the children in school. Looking at the numbers that are being educated versus the numbers that need it would be important.
Yeah, absolutely. Thank you, Dr. Cleary. I think overall, you're absolutely correct. For the most part, much of the SNAPbed programming is typically done in school settings. With the Yakima Health District, we have been moving away from the direct education piece, specifically for that reason, that we want to be able to reach the broader community. So when we've been working with the food banks and we do the surveys there, we do see that there's actually quite a bit of individuals in of older community members that are accessing the food banks and are receiving the services. But yes, in all the work that we do, we have to demonstrate that everything that we're doing is specifically going to the SNAP eligible population. And so for us, we want to do that work more broadly, but you're absolutely correct that in most areas, it typically ends up being focused on the school-aged kids.
And I think there's a certain stigma with obtaining SNAP funds, and the elderly really need to be encouraged that, this is money that they've paid into, this is where their taxes went, and that they deserve the assistance and don't have to live off of $16,000 a year.
Yes.
If I may too, thank you, Lillian. Dr. Cleary, we have spent time working on the issues of food insecurity in our valley. It is very complicated, and in full disclosure, it's painful for me that we are basically the fruit basket for the nation in many ways, and we still have people who, as you say, have difficulty getting to the end of the month with their food supplies, and also having access to fresh fruits and vegetables and so forth. So we actually have been discussing behind the scenes how some of our work actually during COVID could benefit this, because we have created tremendous relationships with long-term care facilities, community outreach organizations that are working with the elderly. So I think you're bringing up a very timely point. Thank you.
Thank you all. Yes.
Thank you, Commissioner Anderson. Lillian, I'd just like to have a little follow-up with you later on. I'd like to know the very specifics of seniors qualifying for the SNAP program. I can get information to certain groups I'm aware of, and hopefully they will avail themselves of that.
Absolutely. Thank you.
Thank you.
Thank you, Lillian. Thank you all. Any further questions or comments? All right, now we will move on to Mr. Porter.
Good morning. Good morning, everyone. Can we bring up the financials, please? Thank you. Next page, please. So reviewing the month of March financials, bringing Q1 to a close, we had a gain of 161,000, very large gain for the month of March. I'll get into a little bit more of those details here in a second. Our allocated budget through the month of March was 5.1 million for revenue, and our actuals coming in closer to 3.8 million for revenue, and for expenditures allocated through March was 5.2, and expenditures were at 3.4. I think we're gonna continue to see differences between our revenue and our expenditures budgeted. It's going to be kind of growing throughout the remainder of the year. A lot of that has to do that we fully funded a test site and a vaccine site, all that stuff for the entirety of the year. Moving to the next page, please. I'm getting into our 161,000. A lot of that has to do with our Medicaid admin claim project, or MAC. It's funding from Healthcare Authority. We haven't really touched on this before. A lot of it is for our what we call our HCE, highly compensated employees. So for like nurses, public health, community health specialists. We go on, or they enter a random moment time study. They do that throughout their week. And when that is all done, we submit billing. We, due to COVID, billing has been behind in MAC billing, but we're hoping to get back on track with that. That brought in about $58,000. Another piece of that is our EH funding. As you can see on here, our fees and permits and licensing is more, almost $40,000 more for the month of March than we had budgeted. Spring has sprung in EH. We're seeing a lot of activity, a lot of building, a lot of food. There's a lot going on. I think we're kind of seeing the same results as everybody being locked up for about a year. We feel like we got to do it double now. So there's just been an explosion of activity. Has there been any questions regarding this income statement so far? Next page, please. Again, not much to note here. Moving into programs. You zoom out just a little bit, please. I would like to point out a newer program. Keep scrolling down a little bit. Actually, I think it's on the, keep going down. It's our FPHS 525 right here, our FPHS drinking water. That is a new program that we have on our income statement. That is going to be where when we're having activities for the groundwater, the Guama, with the distribution of water down in the lower valley, and the Pphs issues up in the upper valley. That's where those expenses are coming from. FPHS, and it'll be funded by our Foundation of Public Health funding, as well as Department of Health. A lot of the plan is that the salaries and wages will be covered by FPHS, and then purchases for supplies like water will be funded by DOH. Next page, please. Just on this page, I just wanted to highlight the vital records. I really don't talk about vital records all that often, but for a year-to-date revenue of $63,000 is an explosion year over year. This time last year, it was half of that. It was $30,000. So we're really seeing an uptick in birth certificates. So make of that. Next page, please. And here is our COVID report. As you can see, we're starting to wind down. It's not up about, because we were spending about $1.2 million monthly fighting the COVID, and we're starting to actually see that in the books, and they'll continue to reduce, in April as we start to continue to close down services. Last page, please. And here is our cash flow. We did have a bit of a dip in cash for the month of March. A lot of that has to do with DOH reimbursement. I've been in contact with them. we kind of expect these large agencies, DOH, DOE, to DSHS to run smoothly, but at times they're a lot like us. They're experiencing the Great Resignation as well. I'm not worried about collecting those funds, but it's just taking a little bit longer than usual. Any questions? Guess I'm not hearing any.
Okay.
Thank you very much.
All right. Well, thank you, Chase, for that report. Any further comments or questions for him? If not, I will entertain a motion to approve.
Motion to approve financials. Thank you.
Is there a second?
I'll second. Commissioner McKinney.
Been moved and seconded to approve the financials as presented. Any further comment?
Only on my copy that I received, the programs are now listed on the page vertically rather than horizontally. It makes it very difficult to read. They're microscopic.
Okay. Any further comments? Hearing none. Mr. Eibach, would you take a roll, please?
Yes, if you approve the financial report for the month of March 22nd, please state yes. If not, state no. Dr. Cleary,
Yes.
Mr. McKinney,
Yes.
Mr. Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Commissioner Anderson.
Yes. Thank you much. We are approved for that. And next, we'll move on to the agency reports. And first up is Mr. Fresco.
Thank you, Commissioner Anderson. Good morning to the board and certainly to our guests. Grateful to be here to discuss a number of things with you. One is the fact that as Chase mentioned, and as we're seeing collectively, we're seeing COVID numbers decreasing. So I want to thank the board again for allowing us to have the strength and flexibility with our budget to allow us, in the event that COVID continued dramatically, that we would have funds. But as Chase mentioned, we have not been utilizing as many funds simply because our numbers are decreasing so rapidly. So we're pleased about that. We remain on alert and we're prepared to respond in the event that there are issues, but we're feeling good about where we're at. There'll be more coming from, obviously, Dr. Barg and so forth in his report. But I don't know if anyone has any questions for me on that issue.
Any questions?
Okay, very good, thank you. The other thing that I wanted to discuss with you is that, as Lillian mentioned, we've been working in the SNAPbed program for a number of years. Traditionally, the SNAPbed program is education based, and what we've been attempting to do over the last 10 years, as you've seen from what Lillian's working on, is really take a different approach, which is we can talk about things that sound very academic, like policy systems and environment, but the reality is what can we do as a community to build community assets and partnerships that strengthen our community and allow us to grow certainly healthy young people, but also how do we create strengthened systems so that we can take different approaches. And by the way, be able to work flexibly to meet the needs of the community. As we discussed with this one program, we're talking about trails, we're talking about healthy eating, we're talking about education and community support, working among agencies. It's complex. And I share that, unfortunately, navigating government is often difficult. And so often what we're dealing with, as Commissioner McKinney appropriately talked about, there are many places where assets could be dispersed that would be beneficial. The reality is that funding is quite categorical and often small. So what we're attempting to do is to create a system, again, building community assets where through partnership with local community agencies and local governments, we can create more opportunity. And that really is about trying to expand the value of our work and to increase the ability for us to have a true impact. It's slow going. Again, we've been working on this approach for a decade, but it has gained, I think, traction at the state level. And I did want to share with you that one of our goals at the health district is to show that a rural health jurisdiction can work on these larger systems approaches and have a true impact in terms of community building. I don't know if I've done it justice, Lillian, but that's what I'm trying to share. Okay. And really the goal is, again, to have these larger discussions that are about multi-year approaches. We would love to see full access for people to walk safely and well in our community. And when Lillian mentions things like our work around building safe neighborhoods and certainly creating safer streets for kids around schools, often the funding stops a block or two from the school, and those children still have to get home safely and well. So we're really trying to work on larger approaches that can help our partners make informed decisions, not to make it harder for them. They already have tough jobs. They already have limited budgets. The goal is for us to serve, and you'll hear us talking about it in the future a great deal, serving as a catalyst for this kind of change and responding, frankly, to the needs of the community so that the health district is nimble to answer the call. Rather than saying, this is how we do things, or this is what public health does, or this is our limited funding, and this is all we can do. We're really trying to expand our portfolio to serve as an organization that builds these community assets. So you'll be hearing more about that. We don't often talk about some of the behind the scenes work, and in fairness, during COVID, we did not do as good a job explaining some of these projects because they really are multi-year. So you'll be hearing more of these in our spotlights. You'll be hearing more about this connection and more about this idea of us being a catalyst as an agency to create change. And frankly, our goal is to really bring in wherever the assets lie, bring them to our community and show that it works and it can be replicable elsewhere. Commissioner Anderson, I'd like to recognize Commissioner McKinney with a question.
Oh, yes, I'm sorry. I was so focused on, go ahead, Commissioner.
Andre, thank you for that. I'm just wondering, we all know that there were a lot of bills that went through our legislature as a result of COVID or during COVID that expanded the commitment that the state has for public health. And I'm just wondering, have you heard if real tangible projects like this are something that are going to be a main focus of funding, because there is an emphasis from the state on spending more funding on local health initiatives. So I'm just wondering if you can kind of expand on what you're at least hearing as far as a priority of funding.
Yes, thank you so much, Commissioner McKinney. I think you're spot on, but I will share that a lot, I believe, of the public health funding will be focused not on systems changes, but on responding directly to the explosion of illness that we're seeing. There were things that were delayed during COVID. As we know, there are subsequent acute health issues, again, that I think that Melissa and Dr. Barr could certainly better share with you more expertly than me. I think that the reality, though, is that there have been root cause issues in our valley for many years, and they became quite clear during COVID. We've had homelessness, we've had poverty, we've had poor health attainment, we've had disease spread, certainly communicable diseases. I think that that will be a main focus. In fairness, I also think another focus from a preparedness standpoint will be something that you'll hear called, and you'll hear more from Nathan, but Cascadia Rising, which is the Cascadian subduction zone, the idea that there are imminent, potentially underground earthquakes that could have an impact on the coast and impact places like Yakima if people had to come here quickly. So from a preparedness standpoint, we're realizing that those theoretical things that are very scary and dangerous can actually happen and happen during COVID. That's where a lot of the focus is. But to answer your question specifically, Commissioner McKinney, we also want to focus on those systems changes, those community changes. We want to focus on the infrastructure changes that allow our community to be more resilient. People who are safer, who feel more comfortable in their neighborhoods, who have access to food, who have access to care, who have access to communication, are going to be able to manage crisis much better. And that's what we talk about when we're discussing resilience. So at the same time that we're going to be looking after funds that are available in public health, we're also going to be pushing back on the state to say, we're building infrastructure here. And it's not infrastructure for the health district, it's infrastructure for the community. If other partners can do it better than us, then so be it. Our goal is to help them do so. I hope that answers your question.
Well, I'm just curious. Yes, it helps. So would you then envision, if you're saying investing in infrastructure, so would that be, for example, trying to help with local food banks and expanding their reach or helping them update? For example, I know that, the SELA Food Bank is looking to, update and expand. Is that what you were kind of referencing, that you would be able to be involved with helping with infrastructure such as that?
Yes, when you mentioned as an example, customer directed food choices at food banks, that's for us, that's not just an issue of allowing people to have choices based on dietary requirements. It's a dignity issue. It's a value and pride issue. And it allows people, I think, to feel better about receiving assistance. If a family is struggling and they require food, or if, as Dr. Cooley mentioned, an older person has limited funds and requires assistance, we want them to receive that care with dignity and pride and feel good about the fact that they're being assisted. That's part of the changes that we're making, but we also want to allow for communication to the community to let people know where things are available. So we may not be able to directly fund a massive program because you can spend, as you know, hundreds of thousands, if not millions of dollars allowing. But we also want to pull back from it and ask the question, why are people having insecurity, or why are people having need? And then again, assist communities in finding solutions. And that may be in the future, helping them find grant money, helping them find community support, helping them find state support. It is really about the connection that the health district can make to better inform those partnerships.
That's great. And I know that we're going to have a big issue coming up, because the legislature has also moved to making sure that we do not throw out as much fresh produce. So as you know, the legislation has passed, which would require restaurants and grocery stores to find a secondary source rather than throw it out. And so I see that as a big opportunity that a lot of our food banks are going to need to grapple with. How do we get all of this fresh produce, since typically it's been a little more of the non-perishable, but yet a great opportunity and challenge to try to help. So
yes, thank you. And if I may also, building the solution is often the hardest part. The motive is there. We have a very loving, caring community here. We have people who want to do the right thing, but sometimes we don't know how to build the system that creates the automated process that gets the food from one location to the other location to the people who need it. We're trying to assist with that. It is really us not trying to build a workforce that does it for them. It's allowing us to help with that process. If you can marry the funding to the project, to the system, to the partnership, then you've done a great deal of good. That's our goal. It just is going to take some time.
Thank you.
Thank you. Councilmember Byers, I believe you had a question.
Yes. Am I on? Okay, thank you. I don't have a question. I just wanted to comment that, during COVID, a lot of things across the board with everyone, Andre, got put on hold or got placed into a lower position. And it is refreshing to me that we are now increasing again the connectivity directly to the community and things that are beyond COVID. And what I really appreciate is you're using those funds specifically as a point of connection and problem solving and solution oriented looking at across the community where we need in all aspects of health in our community. I think that's great. I was happy to hear that we're going to be hearing more about I've forgotten the term, the Cascadian
subduction zone, the Cascadia Rising.
Yes, thank you. I was hearing a lot about that as I became on the city council and the mayor, and then all of a sudden all that stopped because COVID became everything. And when I was hearing about that, I was thinking, wow, this is something we really need to bring out into the community, a lot more education. So there is some preparedness and some awareness. I think awareness is helpful for people. So I'm glad that we're moving ahead in so many areas that you talked about today that are providing awareness and education and helping the connectivity between services in the community and helping people understand those services, get connected to those services and use those services. I think that's vital. I think the health district, it is a limited amount of funding. At the same time, it sounds to me like you can use it very well to accomplish that. And I like the solution-oriented approach. So thank you.
Thank you, Councilman.
Dr. Perry?
Yeah, I think that the timing for this discussion about sidewalks and bike lanes and such is really appropriate because the Washington State Legislature just passed the Move Ahead bill, which is $1.3 billion in transportation funds, which is about 4 times the last bill, which was like $325 million. And a lot of this has already gone to certain projects, but there's a lot of money that is just out there waiting to be dedicated, and it's specifically for safe routes to schools, bike lanes, sidewalks, and other transportation projects. So are you working with any partners or pursuing any of those funds?
Lillian can answer that, please.
Yeah, and so we have been approached by a couple, specifically the William O. Douglas Foundation and a couple others that are looking into that. And we're definitely going to be supporting them to pursue those funds. But in terms of the details, we don't have any specifically, but I do know that our partners have reached out about that and are excited about it.
Yes, if I may, Dr. Cleary, one thing that we found really almost 8 years ago, we were surprised that, as an example, there were projects called Safe Routes to Schools grants. Those were overwhelmingly going to large urban density communities. They were going to Seattle and Tacoma and Snohomish. And we were very concerned. And so we advocated very strongly that rural communities require investment. And so one of the things that we are trying to do now, to tie into what Councilmember Beyer said, is that our projects are not one-off projects. We want to build examples that can be replicated. We want to build a systems approach, again, to creating opportunity in Yakima, but in fairness, we are trying to elevate Yakima as in a place where rural public health can assist communities to grow and prosper and do well. And that can then be used as a template or as an example for other communities in rural Eastern Washington and other, frankly, rural parts of the state. I say that with you candidly because, as an example, when Councilmember Byers mentioned the Cascadian subduction zone, we can spend endless time talking about the theoreticals around that. But the realities that we found, as an example, during COVID is no matter how much time we invested, and we just invested many, many years in preparedness, specifically in Yakima and specifically around the Sundome, we found that there were areas of deficit that we could not overcome because of bureaucracy, governmental rules, and the fact that there were certain capital investments that we could not make, and the city, or rather the city, the county, the Sundome themselves, the organization could not make. We now have a template for what we need to do moving forward. We have a template for what I think the next 10 years could look like in terms of motivating people to invest in things that will keep us safe. The beauty, though, is we're trying to incorporate it so it's not just preparedness for a terrible circumstance. It's preparedness that builds on resiliency, that creates safety each and every day for our residents. That safety model, that resiliency model is what we're attempting to achieve. And one of the reasons that I'm grateful that we're beginning to talk about it is that it's exceedingly complex to be creative and create these sort of systems approach changes in smaller jurisdictions. Large jurisdictions like St. Oakland County have the assets, they have often the staff, they have the expectation, and they have, frankly, the eye of the nation. We are trying to create that same model here. And so I will be asking for your patience and understanding, certainly your questions, and even if you have criticisms and concerns, we want those as well. But what we're trying to do is to build an approach for the next 10 years, and certainly the next 3 to 5 years as we come out of COVID, to say, what is it that we need to do to strengthen this community? What can we as an agency be an asset to other community partners? And what is possible to achieve? Our goal is not just to push a public health agenda, it is to strengthen the entire community. And that's what we'll be bringing to you in the coming months as we prepare for next year's budget.
When the bill was announced, I think the chair of the Transportation Committee even said with some chagrin how much of the money was already dedicated to West Side projects. And maybe it was lip service, but there seemed to be some guilt there and an invitation for programs and counties like ours to pursue additional funds. So again, I encourage us pursuing those for, especially for bike lanes, seemed to be one of the things that was specifically mentioned for rural areas.
Yes, Dr. Cleary, I would like to say, and Commissioner Anderson, having been a long-serving member of our board, knows that one of my responsibilities, I feel, is to go to the places that ordinarily make those decisions and bring those opportunities home to us. I will share with you candidly that expecting people to come to Yakima to see what we need and put us first doesn't work. My job is to advocate very strongly for our community and frankly then be a template for other communities. I think you'll see that in coming discussions about work that we've done that has served other communities because it shows what's possible. And I think that given our size, given the fact that we're the second largest geographic county in the state, given the fact that we're in the central part of the state, all eyes should be on us in terms of our success.
Also, Byers.
Thank you.
Yes. Thank you for calling on me again. Last week, I sat through 2 days of meetings with the Washington Transportation Association, and it was really an eye-opener. Many of the things talked about today, the bikeways, the trails, the sidewalks, the roads, all of those things, particularly in some of the needs in the Lower Valley were highlighted. And the commission travels around to different communities, and they met in Union Gap for 2 days. And so everyone in Yakima had an opportunity, and Yakima Valley had an opportunity to present their projects, their concerns, the needs. And one of the things that kept coming forward, the message to the committee is, we are a rural area who is highly impoverished. We have great need, and it's been unfair competition throughout history in terms of the funds, because the big cities and the larger urban areas have garnered all the funds, and because the small cities had to compete for those same dollars, the rural areas had to compete for those same dollars. So the message was, we need an opportunity to have a pool of money that we compete at a local level, small cities, rural areas, and a portion of it that comes to the east side that meets some of these things, so that it's a more equal opportunity to apply for those funds. And I think they really heard that message. I think that is critically important that they do. But also, I think, Andre, that might be a good place for you to connect. And a person that you might want to connect with is Alan Adolph, who does the roads and transportation issues for YVCOG. So in terms of being part of the communication, giving and receiving information, help finding ways to emphasize and help, I think you could have a good conversation with him.
Thank you, Councilmember Byers. I do want to share something in earnest, that we were poised to begin a lot of this work pre-COVID.
Right.
And so one of the things that we have discussed, in fairness, was our recognition that we have a large county, we have a very large city, and then we have smaller cities. And our goal was to allow for whatever we did with one organization or one municipality to be shared transparently with others. One of the models that we're trying to achieve here is the idea that we cannot expect a small city to have the assets to have everything in place in terms of infrastructure, growth, urban planning, grant writing, all of it in one place. That's unfair. What we're trying to do is, again, create this community asset model where we can create a template for all cities in our valley or all community clinics in our valley, so that every opportunity is made to share that transparently. That's been our goal from the beginning. So again, we are trying to become a test demonstration site, I think, for the rest of the state in how good governance looks and how information is shared. And frankly, this is a very big sea change for public health. Normally, public health does projects where we say, we're focused on a school, we're helping educate them about healthy eating. Their parents may not make changes. So we may have invested a lot of time, but we may not have had the results that we intended. We're trying to take a larger systems approach. And again, I'm grateful that you're interested, because this is really, I think, the future of our work. And frankly, we cannot fail at this. There are too many people suffering in our valley, and we have many acute health issues that need to be addressed. And there's no way to do all of it at once. So thank you so much.
I would say, Mr. Fresco, that you may want to have a conversation with Chris Wickenhagen, who is Executive Director of YVCOG, because their solutions to many things are similar in terms of they provide some systems work with smaller cities who don't have the staff to do it on their own in a variety of areas. So it may be helpful just to have a general conversation on what they are doing and maybe how you could work with them or they could work with you. So.
Yes, thank you. Actually, we worked for many years with YVCOG very directly with Larry Matson. We did assist Chris Wickenhagen and worked with them on a number of initiatives. Again, I think we have to get back in our rhythm after COVID. But yes, all these things are wonderful assets that we're looking forward to working collectively on. Thank you.
Thank you.
Thank you all. Any further comments or questions before we move on? Hearing none, we'll move on to Chief Operating Officer Ryan Ibach.
All right. We're going to talk about Board of Health membership recruitment. So currently there are 3 open positions for the Board of Health, according to House Bill 1152, which requires us to expand the board. Those 3 positions are, one is the tribal position. So we have reached out to the American Indian Health Commission, who is the entity that will be selecting that member. So we reached out to them last week, sent them a letter and inviting them to select a member for the Board of Health. And so we will continue to reach out to them, make phone calls and be in communication with them to get their progress and get status on where they're at in their process. And so we'll be reporting to the board as time continues. The other 2 positions are the consumers of public health and other community stakeholders. So we started advertising for those 2 positions. We've been advertising in the Yakima Herald, on our website, on social media, and also we've reached out to community-based organizations, coalitions, and other community partners. That does close on May 11th, and so any applications will need to be turned in by May 11th. So just to go over what those 2 positions are, consumer public health consists of county residents who have self-identified as having faced significant health inequities or having lived experience with public health related programs such as the Special Supplemental Nutrition Program for Women, Infants, and Children, which is WIC, the Supplemental Nutrition Program, SNAPbed, which Lillian talked about earlier, home visiting or treatment services. These individuals may not be elected officials, may not have any fiduciary obligation to a health facility or other health agencies, and may not have a material financial interest in the rendering of health services. The other position is other community stakeholders, which includes persons representing the following types of organizations located within Yakima County. So community-based organizations or nonprofits that work with populations experiencing health inequities in the county, business community, or environmental and public health regulated communities. So on May 12th at our special meeting, the board will be discussing how we want to pare down the candidates and how we're going to select candidates that will be interviewed, and also discuss the interview process. Then on June 9th, so then we'll do the interviews, and then on June 9th, there'll be a special meeting, our Board of Health special meeting, in which hopefully the Board of Health will be able to select the candidates. And then after that, the Board of County Commissioners will be appointing the Board of Health members. Any questions on that process before? Commissioner Lindy?
Yeah, thanks, Ryan. I was just curious as to how many applicants you've seen so far.
So far we've seen 1 applicant.
Right, thanks.
So hopefully as time gets closer, that we start seeing a lot more applicants. Any other questions? Okay, and then one thing I also wanted to bring up just for consideration, it doesn't need to be a discussion point now, but just something to think about before the May 12th meeting is right now we'll be having 4 citizen positions. And they're going to be out of alignment. And so in order to get them in alignment, just a couple things to consider. One would be, so we'll be bringing on 2 citizen members July 1st, but then we'll have another citizen member position open at the end of the year. And so, so we'll have 3 positions, but they're not in alignment as far as advertising. So in 2026, when we have to advertise again, we'd be doing it twice in 1 year. So maybe a consideration would be that first time, maybe 4.5 years, so that we get those positions to the end of the year. But then that also puts us, as far as being staggered, 3 positions in 2026 that we'd be advertising for, and 1 position in 2024, citizen position. So maybe a thought would be one of those new citizen positions is a 2.5-year term, one's a 4.5-year term. That way we'd have two positions in 2024 that we'd be advertising for, and 2 in 2026. So just something to consider that can be part of a discussion on May 12th.
Brian, I think that it makes the most sense to stagger them and put them over to where every year you're replacing 1 member on a 4-year cycle.
Yeah, and that'd be something to consider, and then we'd have to figure out how we'd get that staggered and how many years each position would be that first year. So. Any other questions? Okay,
Other questions? No comments?
that's all I have.
Thank you, sir. We'll move on now to Dr. Barg.
Morning, everyone. I hope in the future we'll be able to talk more about bike paths than COVID as a 22-year bike commuter in this town. So what's going on with COVID? CDC has a new way of determining where you're at risk. And it's a combination of COVID admissions, the percentage, community transmission, and also the number of beds occupied in the hospital by COVID cases. And all of that taken together, we're green. Green is good. There are other ways of looking at this, but this is a way that's easily comparable from county to county. And our community transmission rate is much lower than it's been in the past, although the number of cases are going up, the number of deaths are not going up, and the number of hospitalizations are going up a small amount. We've had multiple days in the last 2 weeks with 0 COVID patients in the hospital. You should see how people are smiling when you walk around. Part of this, and I don't know for sure, may be due to the availability and the use of home tests. And I know I've heard people say, oh, you know, I tested positive, I'm not going to that music festival, or I tested positive, I better stay home from work. So I think the home testing thing has potential to really sort of undo the number of high hospital admissions and deaths that have been going on in our county and elsewhere. We also talked a little bit about Paxlovid last month, which is the antiviral medication that's available. There's a website that's been put out that you can go to county by county and show you who's got what drugs for treating COVID. It's aspr.hhs.gov. And I did that, and Yakima County shows up. And we have, just as an example, Neighborhood Health is a test and treat location. Rite Aid has both of the medications, Paxlovid and the Molnupiravir. Walgreens has it. Multiple Safeways have it. There's another pharmacy, River Village, that has both. Summit View Urgent Care has both, and Walmart in West Valley has Paxlovid. So all we have to do is still get more information out to the local physicians about writing the prescription for that. There was a bulletin that Melissa put out to providers with that information between last meeting and this meeting. So people may be thinking about, what about this new variant? It's been named BA2 or Omicron BA2. Right now, 94% of the current COVID infections are being caused by this strain. And last month, it was about 20%. So this guy is really moving quick. But because the hospitalizations and death rates are not rapidly increasing, that might indicate that this strain of the Omicron isn't nearly as dangerous as the original Omicron strain. There is some pathogenesis information out. This particular virus doesn't appear to replicate quickly in lung tissue. In fact, it seems to be more confined to the upper airway, the nose and the throat, and killing of those cells or injuring of those cells is much less dangerous to you as a patient. There's another issue that has come up. There's more and more information about post-COVID sequelae, and these occur or are most intensively studied in hospitalized patients. It seems to take between 5 months and a year for patients to fully feel that they're back at their baseline. And the symptoms that seem to persist are fatigue, muscle pain, generalized slowing down in your activity, poor sleep, and shortness of breath with exercise and at rest. So that's an issue that, of course, will decrease as the active cases decrease, but it's still, we're concentrating so much less on active disease because of the occurrence of it. We're now starting to think about the post-COVID sequelae. So you only get that if you get COVID. So if you get vaccinated and you don't get COVID, you can avoid that. So that's some other things here.
Dr. Barg, I'm wondering if we can recognize Commissioner Lindy with a question, please.
Oh, sure. Sorry, I was looking at my notes more than the screen. Go ahead.
Yeah. Thanks, Dr. Bark. Appreciate the information. I do have a question. Is going back to the and the rate of spread right now. I just happened to read an article in the newspaper this morning that the CDC has done a test about infection among the population, the COVID infection, and they had come to the conclusion that we had about nearly 3 in 4 of our youth, or 75%, that have been affected with COVID, and I think 60% of the general population. And I'm just wondering if you might think that also might be a contributor in the slower spread of the illness at this point.
I think the spread is probably going on just as much as it always has, but the significant symptomatic disease and serious disease is being tempered by previous exposure and vaccine. So that's really playing a role, I think, in the number of hospitalizations, because that's the endpoint of severe disease. So yeah, I think the fact that we have so many people that have antibodies through natural or a vaccine is playing a role in what we're seeing here, or let's put it this way, what we're not seeing, which is problems.
Thank you.
Great. There's another monoclonal antibody that's available for post-exposure treatment. The name is much too long to try and pronounce correctly. It looks like bebtelovimab. I don't know if we have any in town yet, but the administration, this has to be done in a location like the old COVID clinic that got ramped down recently. But there is still new stuff being worked on, and we're getting more and more into equilibrium in regard to what we have and how we can respond. Feds also plan to increase the Paxlovid supply, and hopefully it'll become as available as, let's say, Tamiflu for influenza. Commissioner McKinney, you had a question?
I was just going to say, Dr. Barg, if you could jumble those words, it makes all of us normal people feel much better about ourselves. So the more you can tell us that it's difficult for you to pronounce, the better we all feel. So
in full disclosure, in all my decades in public health, Dr. Barg is the first to admit that he doesn't necessarily like these, which I think is a great lesson in humility.
Well, we appreciate it very much.
It's not hard to be humble around COVID. So one of the things we've touched on in the past that's being emphasized more and more is indoor air quality. And I don't think the various funding agencies at the local, state, and federal level have gotten ramped up to this to provide funds for increasing ventilation. And before they do that, there's a couple of immediate easy solutions. One is, now we're getting into nice weather, open the doors and windows in classrooms and small stores, wherever the air circulation isn't optimal for disseminating or dispersing the COVID particles. Also, buildings can be set up to pull in more outside air rather than recirculate the air in there, bring it in, put it through filters, distribute it, and then blow it out. That's one thing we can look at the big gathering buildings in town. And finally, for like small places with high-risk people, let's say a nursing home, there are portable HEPA filters that can be bought and placed and will trap the airport particles containing the virus. So this would be like application if you had a cafeteria in a nursing home. You could get a HEPA filter in there. Whether they have the funds or not to do that, but is unknown to me, but certainly an option for improving indoor air quality. And compared to, say, distributing a drug like Paxlovid widely and getting knowledge out to all the providers, this indoor air quality solutions are much easier to potentially implement. So let's see, I think I got one more. Couple things have been published in MMWR. We actually had more COVID deaths in 2021 compared to 2020, but I'm kind of optimistic about 2022. At the current time, COVID deaths, looking back, are the number 3 cause of death, with heart disease and cancer being the other 2 that are greater. Another paper was published in JAMA in April, surveillance of safety of the 3 doses. There's no significant increase in adverse effect after the 3rd dose, which is technically your first booster. There is an increased severity in low, rather an increase in frequency in low severity events, but that would be like muscle pain, fatigue, and none of those end up causing a lot of problems. A new test may be around the corner. It's a breath test. So if you get stopped by policemen, you can check your COVID status and your alcohol level. But seriously, there is a breath test out, which will make it a lot easier for, say, kids and people that are squeamish about having swabs stuck in their nose. That should be available.
So doctor, could people purposely get stopped just so they can have a breathalyzer test?
Well, I think the alcohol will go on your record, but the COVID won't. So as far as I know, COVID won't increase your insurance premiums for driving. There's another new monoclonal antibody. It's not a monoclonal antibody, it's an immune modulating agent for people that have serious disease and have lung damage. They're in the hospital, they're moving towards or early on a ventilator. And it's actually responsible for 55% decrease in deaths when it's used. It's still investigational, but they stopped the study because there was such dramatic positive effect. And that drug, bear with me, sabizolubinin. I don't think I said that right either, but I don't think we have any of it in town yet because it doesn't have an EUA, but an extremely promising drug available for treating severe COVID. And so with that, I'll stop my COVID thing and then be happy to work on bike paths with anyone.
Any questions or comments, Commissioner McKinney?
I appreciate your update. The one thing I know that's happened since we last met was that the State Department of Health Board did vote not to make compulsory vaccination for COVID for school children. I just wanted to express my gratitude to everyone on this board. I know that we wrote a letter cautioning and asking the State Department of Health not to move forward with that as long as that was still not receiving full approval. And Dr. Barg, you touched on this. I think it was a wise move. We always want to encourage people to seek out advice, especially regarding vaccinations or any preventative medicines from their doctors, but making it a requirement and mandatory took that decision away potentially from parents. In 2022, 0 to 19-year-olds represented 32% of the cases in Yakima County, but 0% of the deaths pandemic year to date. In 2022, only 3% of our hospitalizations were 0 to 19 that were at least COVID positive. We do not know if they were even admitted because of COVID or with COVID. So our youth, and to Commissioner Lindy's point, 75% are deemed to have acquired natural immunity at this point. So our children are very resilient. And I just want to note my thanks to the board and especially to the Department of Health for noting that it was not a right move to move forward under the circumstances.
Thank you. Any further comments, questions? Thank you, Dr. Barg. We will move on to our local emergency response coordinator, Mr. Johnson.
Good morning, everybody. So to just give some quick updates around community-based vaccines and testing. End of March, we ended or suspended our last mobile vaccine team. So since then, we've kept an updated list on our website of places that the community could go and get the vaccine, as well as we're planning some community events, a couple of them each month in partnership with Washington Department of Health's what they call a Care of Van, which is basically a mobile vaccine team that community partners can request to support a vaccine clinic at a community event. So there's still options out there with vaccines, with testing. UW Lab that has been supporting the Sunnyside site and the Yakima Valley College site. They have chosen to suspend the Sunnyside site, and that occurred after the 21st of this month. So at this point, that site is now closed. as well as the Sundome site. We do still have the Yakima Valley College site that is open, still funded and supported through UW Lab, and UW's committing not only to keep that site open for the next several months, but also to make sure that we have a plan in place. If we do see a large surge, we can request another Lower Valley site and get a Lower Valley site up and running within about a week of making that request. As we kind of are in this transition period, and we want to really capture some of these best practices and lessons learned throughout these last 2 years, we're looking at what is called a after action report would look like for us. This would be a multi-pronged approach where we're able to gather not only input from current staff, but also community partners as well. That has really supported some of these core response initiatives over the last several years, so we can really identify what those best practices are, and also be able to carry those over outside of COVID. Not only in just looking at the next disaster, but also just preparing for a more resilient community in general. With that, we've already mentioned Cascadia Rising. So as we look towards the future, Cascadia Rising is coming back to light. It was talked a lot about prior to COVID on a local, state, and federal front. This is the concept of a 9.0 earthquake occurring throughout the Cascadia subduction zone with no real epicenter. So it would run from California all the way up to Vancouver, Canada, and really have some catastrophic failures of critical infrastructure throughout the path of that. It would include not only an earthquake, but also the possibilities of tsunamis, waves as high as 13 feet around the Vashon Island area. And so from our standpoint in Yakima, these conversations are really starting to come back to light on a local, state, and federal level. And trying to take a lot of these lessons learned around how we responded to COVID and really rallied as a community and apply these to how we're looking at Cascadia Rising as well. And we're very uniquely positioned here in Yakima to be really in central Washington and be in a optimal location for positioning resources to support the west side as needed if something like that happens. One thing I did mention is this earthquake has actually happened. It happened 322 years ago, and it is an event that occurs every 200 to 500 years. So we're definitely due for that event, and we want to make sure that we're prepared and in a position to respond well for the community. So that's kind of what we're looking at that. You'll hear me talk a little bit more about Cascadia Rising in the coming months as there's some FEMA-led exercises and really a strong pull to start the planning process back up around that topic. And with that, I will pause for any questions.
Nathan, oh, I'm sorry, after you.
Any questions for Mr. Johnson?
And I'd just like to politely add, if I may, if we were to have a catastrophe on the west side and people were coming in droves to the east side, they're not going to take a left to go up to Spokane. They're going to come right to us. So I share with you in earnest that, again, what is good for Yakima is good for the state. And so we are looking to position. And one thing that I think Nathan's being humble about is that we've built tremendous rapport in previous years with the Region 10 Health and Human Services group, the group that is responsible for the work that we actually did during COVID. But during COVID, we really became a model, not just regionally, but nationwide in terms of creating mobile platform, creating really unique solutions to complicated issues for rural communities. And frankly, we were a place where people came to get great COVID care from the other side. So we want them to invest in us.
Thank you. Any further comments or questions? Hearing none, we'll move on to disease control by Melissa Sixberry.
Okay, good morning, everyone. I'm not going to talk about COVID today. I think Dr. Barr did an excellent job covering that. So Other things going on in communicable diseases, we currently have 2 active TB cases that we're managing. And we also have two suspect cases that we are waiting on cultures to either confirm or rule out as TB, but we do treat them as TB until we rule them out otherwise. And then another one that we're working on, so potentially 5 active TB cases that we're working on. We're also in the middle of a syphilis outbreak going on within our community. It's mostly in our homeless and drug using population. It has resulted in several congenital syphilis cases, and in about a 10-day period, we had 4 congenital syphilis cases, which is unheard of. I mean, we just have never seen this before. Syphilis is rising not just locally, but statewide and nationally, and likely due to the lack of access to care during the pandemic. It prolonged people going in and being diagnosed, delaying treatment, which just further spreads the disease. And so we have worked, Dr. Barg and I both have met with the State Department of Health, and they're helping us in figuring out a way we can do some targeted messaging. We're going to be getting some rapid syphilis tests from the State Department of Health that will be going out and doing in the homeless population and drug using population to screen and then have available testing for them for confirmatory testing if needed. We also have the ability to treat these individuals. So we're working at all different angles. I don't know, Dr. Barr, if you have anything else to add from that conversation that we had.
Yeah, we're starting to increase the testing that's done in the big clinics in town and the emergency rooms. We're recommending that all of the syphilis tests be done instead of the cascade. There's 2 different types of tests. One is a screener and one determines what phase of syphilis the patient might be in. There's a big delay between getting the screening test and getting the test that tells us how to treat the patient. Now we're just saying to these large clinics, do it all at once, and then we'll know whether we need to treat earlier, and the earlier we treat, the less spread that there'll be. So we're still working on getting the testing scheme up in all the places. I've sent emails out to farm workers, neighborhood health's involved, and we'll be talking with the emergency rooms who are actually a little bit ahead of the curve right now.
And we're able to pull reports and determine where most of our cases are being diagnosed. And so we have been able to determine there's some facilities we suspect should have more than we're seeing, which could mean that they're testing for gonorrhea and chlamydia, but not necessarily for HIV and syphilis. And so we're doing some targeted messaging on that. Commissioner McKinney, I see you have your hand raised.
So you've mentioned before, and we know this, that it's in our homeless population. So I'm curious, is this, are you seeing in more of the homeless population that are actually the illegal campers, trespassers who are not typically in, say, for example, a place where they're being provided services such as Camp Hope? And if we are seeing this among those who are legally camping, how is messaging possibly going to get to them other than finding them on the river? And obviously it's not going to be social media, radio, or television. So how is the messaging being conveyed?
Absolutely. So I've spoken with Comprehensive Healthcare, who works a lot with substance use. They have a methadone clinic there. Some of those individuals are still in communication or actually still actively using drugs and still seeking services. And so that's one way we're going to be getting our messages out. Our needle exchange crew are very in tune with how to get messaging. When you tell like the inner person, you find your one person who then notifies the whole group. We do a lot through that. Neighborhood Health also has outreach nurses for homeless, and they really do go right to the river and work with those individuals. So several options for trying to reach them, but usually once we let the homeless community know, the message does spread. We've had to do it for things such as wound botulism. That's usually how they get their messaging, is by word of mouth from each other.
And we actually managed a hepatitis A outbreak just before and actually during COVID. And again, creating those trust relationships with a community of people who communicate person to person has been very helpful.
Let's hope we can get them off the river, since they don't belong there, and we can get them closer to where they should be, which is close to resources.
Right.
Well, one other issue, if I may bring up, is the reality that we were really destabilized in this community when we lost Regional Hospital. Losing that hospital just before COVID was catastrophic. I think we will continue to see the repercussions of that. And it's not just the physical presence of regional, it's the reality that we lost literally hundreds of practitioners in our community. So I'm sharing with you that there's a great deal that we as a community need to do to move past these issues because we really don't have the resources. And again, traditionally as a rural community, we've always been what's considered a health professional shortage area. So we will be really working on that actively. And again, Melissa has been working with Lillian on communication, and Dr. Bark has embraced this provider resource website that we created in partnership with Tacoma Pierce County, which gets information very quickly to providers in our community. Thank you.
Thank you.
And DOH also, we were talking about how we don't, DOH doesn't seem to look at us for resources and funding, but they have recognized this is a problem with the syphilis. And so they have committed to funding for a full-time nurse starting midsummer to do nothing but STD work specifically for gonorrhea and syphilis in Yakima County. So that's, we'll be happy to have that. I think that will help a lot. And then also our enterics, which is our diseases that cause diarrheal symptoms, nausea, vomiting, diarrhea. We're seeing an increase in that, nothing out of the abnormal prior to COVID, but definitely more than last year. It seemed like with the pandemic, those cases were really far and few between. People weren't barbecuing and as much and having get-togethers, and but we are seeing that go back to normal again. So, and then I know on the agenda is for overdoses, and so I'll have more information to share when we have that discussion.
Thank you. Any further comments or questions?
Commissioner Anderson, I'd just like to recognize that Councilmember Duval joined us.
Yes. Welcome.
Thank you. Good morning.
Any further comments or questions before we move on? If not, environmental health, Mr. McGee.
Good morning, everybody. So I have three updates on some major initiatives that we're working on. I'll try to keep it as brief as I can, but I'd like to start with the PFAS contamination near the Yakima Training Center, give an update on what's going on with that. If you don't know, PFAS stands for per and polyfluoroalkyl substances. I've been practicing, so I wanted to say it. So the Army has committed to a phase 3 testing area. We have a general idea of where that phase 3 area is going to be. It's expanding further to the west and southwest of the training center, pretty much coming all the way down to the Sela Gap, and then bordering to the east, I-82, the interstate. There's a few parcels to the west of the interstate that they're also going to be looking at. So hopefully we'll get an idea of how far the plume of PFAS has traveled. I imagine if there's contamination over the EPA lifetime exposure limit at the edge of that phase 3, we could expect a phase 4. So the sampling is, I believe, supposed to be conducted in May, and hopefully have results of that in June, July, and it'll give us a better picture of what what the plan will be moving forward for the Army on the wells that are above the EPA limit. The other issue we're looking at, and we're working closely with DOH on this, is the wells that are over the state action level for PFAS lifetime exposure limit. Quite a big difference in that the EPA's is 70 parts per trillion and the state of Washington is 10 parts per trillion. So DOH, we're still looking into it. They're still looking at how it would work and the logistics of it all, but they may have identified some funding that could help, potentially bring more potable drinking water as a stopgap until we have more long-term solutions in place, but at least to limit the exposure to the folks who are affected. So we are working with DOH on trying to explore funding options, and if we get funding, what will we do with that as far as relief for these folks? There is a lot of talk, obviously about This is a bioaccumulative substance, so it can get into the meat of animals that are raised for consumption. Obviously accumulating in pets, is a big deal to these folks as well. So that is being talked about. DOH is also reaching out to vets who have experience dealing with PFAS in animals. So now what we're doing in the meantime is working with Lillian and her team. We're developing a website that's going to have a lot of the general need to know information about PFAS, and then also some resources for folks, if they want to go out and get their well tested privately, where can they send their water sample to? What different treatment system options are available for purchase for them? If they don't want to wait on the Army or the state funding that might come available and take action themselves. We want them to be in the know of how they can do that. So we're working on that, and we're hoping to have that up very, very soon. Are there any questions? Oh, also, I am in weekly meetings with the Army and with DOH talking about the open public meeting that's happening on May 26th. There will be two-hour sessions on that day, one in the afternoon, one in the evening, for the public to come and ask questions, voice their concerns, and hopefully we'll have a lot more information to provide them.
Commissioner McKinney.
Sean, I just want to thank you for taking part in those meetings and just say that you touched on one thing that causes a lot of confusion, which is that the federal government has a different criteria or limit, and the state does. And right now, the Department of Defense and the Army are committed to providing water for those whose wells have found to be exceeded the federal limit, but not the state. And so that's why there's kind of a disparity between the two, whether or not it comes from state funding or federal funding for water. And then just glad to see the Department of Health still continues to expand. And as we know from the meeting that was held for the folks that were known already to be directly impacted, that they're still studying. And so there is just not enough information to be able to say a certain amount of contaminant found in the blood levels of beef or even a human. What is exactly the limit, and what you should be concerned for. So it continues to be very unfortunate, but I really appreciate you taking such an active role. And just want to make sure that you're coordinating, I know you are, with our public services, because Yakima County already does have a website that we put up to be forward facing to try to make sure that we were providing FAQs and resources and links to the Department of Health, to the Department of Defense, and well testing. And it is quite expensive. It's about $500 to $800 to have your well tested if you want to do it proactively. That's a big ticket item. And then what do you do with it? When you get that test back is a whole nother question. So just appreciate your participation on a regular basis as we work on this really significant community event.
Thank you. Dr. Cleary.
So Sean, I was just wondering, you used the word plume, and PFAS can be spread through a lot of means, certainly just in the ground, through groundwater into people's wells, by animals eating vegetation that's on the property, but a lot of it can be spread via dust. And I don't know if that's what you were implying, and if that's the case, is anything being done to secure the source of the contamination on the firing center? Because in addition to a health risk for the people in the immediate vicinity, it's devastating financially because it is rendering their properties essentially worthless, regardless of the extent of the health hazard.
I haven't heard in any conversations between DOH and the Army any talk of dust or windblown contamination. What they believe is happening was the years and years of continuous use of the firefighting foam allowed it to leach into the groundwater onto the training center, which the direction the groundwater is moving is down towards the community of East Sela. So that's the primary concern, but that is a great question and a great point to look at. Like, is there any surface contamination in the soil and can windblown, be
Dr. Cleary, I
negative
certainly
impact.
am not an expert, but what I've learned from visiting with the Department of Health is that the concern is mostly that it's skin barrier. Your skin is a barrier to this, and their concern is how it enters your physical body is through ingestion of, because it's leached into the water source. And so that was more of the concern from the federal and state health officials that were there, not from dust or anything on the surface, that it was mostly because it had found to be leached into the water source and then you ingest it, and that's how it particularly impacts you. But I am not an expert, so.
Yeah, there are actually studies that show it can get airborne, and it's actually been detected in kindergartens and schools, in areas that are contaminated. And so there is airborne spread of it. And again, it's whether that's a health issue or not is questionable, but if somebody detects PFAS, it's a disaster politically. It renders the property worthless. So it still has to be considered. And there are techniques for in either removing soil that's contaminated or producing new growth on top of it to limit the spread of the dust. And so whether it's a health issue or not, it's a financial issue.
Well, that is, a good point and a topic that I'm happy to bring up in these meetings.
Thank you. Any other comments or questions?
I have a couple more items real quick
Okay.
to touch on. They
All right.
won't be nearly as long as the PFAS. For our Guama Safe Drinking Water Initiative, we are beginning water deliveries this week. So far, we've had 38 homes sign up for delivery. This will be serving about 155 individuals, is our latest numbers from late last week. We have funding secured to deliver this water through 2022. And Office of Drinking Water DOH is hopeful and confident that they'll be able to fund this well beyond 2022. So this initiative is built to be flexible. We can take new people on within the Guama as they want to sign up. We're looking at ways to get the nitrate test strips into homes, into people's hands, so they can test their water quickly and it's accurate enough to determine, you should be on the Safe Drinking Water program. So we're working on those initiatives, as well as Lillian and her team are conducting focus groups, kind of researching, what are the people within the Guama want to see happen? What different treatment options could we potentially bring into the Guama into the future, and building those relationships and those trusts, so that when we do, initiate these projects and these relief efforts, we've gained people's trust, which goes a long way, because we're asking them to essentially let us onto their property, into their homes, and make changes to their home. So it is a big deal, and I think these focus groups will go a long way.
Thank you.
My last item I want to touch on is the abandoned homeless encampments along the Yakima Natchez rivers. I've been sitting on a committee talking about the homeless encampments, active and abandoned, along the Natchez and Yakima River, basically from the Sela Gap all the way down to Yakima Valley Boulevard is the main focus, as well as the Toppenish Wapato, as we get reports of abandoned camps being in that area. So what we've done moving forward to tackle this initiative of removing solid waste, refuse, hazardous materials from these abandoned camps is here at the Health District, we've started the process of amending our solid waste grant to dedicate some funds to work in partnership with Yakima County to help clean these abandoned camp areas that are along the river, with the concern that we have, high water events that can wash the stuff into the river and downstream, affecting communities also downriver. Going into the summer, we have higher fire risk in that area, as we've seen. I've driven by it a couple times and seen some smoke coming out of the woods there. So the goal is to provide funding to help the county, pay for staff time, heavy equipment rentals, things that are needed to remove the garbage, the refuse, and other potential hazardous materials from the riverbanks and get them to our landfills and properly disposed of. So we are in the amendment process of that grant now. We're making progress, and hopefully we'll be wrapping that up in the next week or so. So just wanted to make the board aware of that initiative as well. It's in progress, and we're getting there. Any questions on the homeless encampment, abandoned homeless encampment?
I have something to add, if I may. I just would like to remind, update the board that with this DOE grant, it's a 75-25 split. So for the $60,000 that we're getting from the grant is $60,000, but 25% is covered by Yakima Health District. So of this 60,000, 15,000 will be directly from Yakima Health District, and we plan on using flexible funding for that.
Thank you, Chase. Any further comments or questions?
Looks like Commissioner McKinney has her hand up.
Oh, yes.
I just again wanted to say thank you for your efforts on this. This is a high priority for the county. We've already heard that the homeless who are illegally camping and trespassing on these lands are causing harm to themselves, to the environment. And we've got to continue to not only clean up the destruction that they're creating, which is a danger to people who are wanting to visit these beautiful areas. It's a safety issue. We also have to figure out how to get these folks permanently off. This is something that is an ongoing issue, and we see what happens when you just need to go to downtown Seattle to see what happens when you decide to tolerate this kind of living environment. So we truly appreciate the partnership that the health district has provided at the county level, because this is a high priority to protect our waterways, our riverways, and the area that we want to enjoy. We're talking about being able to have kids bike and walk on these beautiful pathways, but if they're unclean and unsafe, then who's going to want to go there? So it's really a high priority, and it's a good partnership.
Thank you, Commissioner Lindy.
Yes, thank you. I just want to probably mostly echo these sentiments. As someone who sat on that committee with you, Sean, I really appreciate the health district's engagement on this issue. It is a high priority for us throughout the county. We hear it from those people that try to walk and enjoy the Greenway, which is a gem of our local area, for our businesses that feel threatened. And of course, we have compassion for the people that are in these conditions, but true compassion is really, helping them not just change their location, but their conditions. So hopefully we can get them into a better spot so they can be, more self-reliant, productive members of the community. Thank you again for your efforts.
Thank you.
Thank you. If I may, Sean, if I may add, I'm sorry, Commissioner Lindy, were you done?
Yes.
Okay, thank you. I did want to share with you that the grant that we're using, and again, the commitment that the health district is making, as Chase pointed out, there is a portion that we are responsible for. Again, this is for solid waste disposal. It is dealing with nuisance issues. So I just want to clarify that I recognize that in our valley, we have many issues to deal with, especially people who are living in complicated circumstances like homelessness. But this specific grant and the appropriate delivery of our response to meet the requirements of the ecology grant is based on abandoned homeless camps. So I just want to clarify that again is our responsibility from an environmental health recovery standpoint to minimize nuisance and potentially the tragedy of fires and additional dangers from illegal substances and so forth. So thank you.
Thank you. Any further comments or questions? Not, we'll move on to public health partnerships with Lillian.
Thank you. No, as you've heard, our department has been supporting some of the other departments and some of our new initiatives for the most part. Our other programs have been running smoothly. So the one update that I will share with you all, it's an invitation. As Nathan mentioned, we are going to be continuing to provide community-based vaccine opportunities in partnership with the Department of Health Caravan. So we have the DOH Caravan coming to the Sunnyside Cinco de Mayo Parade next Saturday on May 6th. So we will be there in as well, sharing space with the Latino Community Fund, and we will be providing the COVID-19 vaccine for anyone who is receiving it, and also we'll be providing the first and second booster for those that are eligible. So I definitely invite you all to come and see the first community-based vaccine event after our mobile vaccine team has sunsetted. We're excited to be working with community-based organizations and hope to have a good turnout. Yes, Commissioner Lindy?
Yeah, I just wanted to maybe clarify. You said you're going to the Cinco de Mayo parade. The parade itself, I believe, is on Sunday.
Oh, excuse me, the event then. So we'll be there on Saturday. Thank you.
Okay, all right. All right. I just want to make sure if you're showing up for the parade, want to make sure you did.
Thank you for that.
Okay,
All right,
thanks. Yeah.
All right. Any further comments or questions before we move on? All right. Well, our next item is unfinished business, and on my agenda it says none. So we'll move on to new business and Yakima County Code Chapter 6.04 with Mr. Elliott.
Good morning, everybody. You should have received, I believe it was within the last week or so, 4 different documents that had come from either Victoria or from Ryan. What you should have received would have been a letter from the prosecutor's office to me on April 9th or April 18th. Along with it, a copy of the attached proposed final draft of 6.04.010. In addition to that, you should have got a copy of my email communications with the prosecutor's office and with the county commissioners, in addition to a copy of WAC 24690, which relates to local Board of Health membership. So we've talked about this issue before. The purpose in getting all this information to you all was, my understanding was the county commissioners wanted to make sure that both this letter and this new code, which will deal with the compensation of the board, would be disseminated to you. So when I received the information, I gave it all to either Ryan or Victoria to send to each one of you. Hopefully you've had a chance to look at these 4 communications. In terms of this process, I just want to identify, I appreciated the prosecutor's office reaching out to me and looking for my guidance related to how I read these rules. As you can see, hopefully you had a chance to see from the email communications, they offered me that opportunity. I had identified some suggestions for them. And then as a result, as you noted in the letter that was written from the prosecutor's office, they responded back to my suggestions. So what you have now in terms of all of these pieces of information is everything I have to date in terms of where things are related to this issue, which is the board membership, the process related to board membership. And my goal in getting all of it to you was allow you the opportunity to review it. If you had questions for me, that I would be able to answer those. But I basically wanted to let you see everything that happened in the process here. So you now have all the information. And I don't have anything to present other than I think it all lays it out in terms of where positions are. So.
Okay. Thank you. Any questions or comments? Council Byers.
Yes. Mr. Elliott, I just wanted to thank you and everyone else involved in the communication and getting all the information to the board. I think it's very helpful. I think it clarifies some things and answers some of the initial questions we had. So thank you very much.
Ms. Duval.
Yes, good morning. I had a question about the document chapter 6.04. In that first paragraph, being that I am a city representative, I do want to bring your attention to the sentence that says provided that no elected official is eligible for reappointment to the Board of Health if his or her term expiration date would leave a midterm vacancy on the Board of Health. I just want some clarification about that, just because I know that my 2-year term is up in 2022. And my elected position is up in 2023. Does the way that this is written, would that disqualify me from wanting to serve on the board again? And that not only myself, but also Councilwoman Byers would be in the same boat. And I went ahead and did some research. Out of the 14 cities and towns of elected officials, that would potentially disqualify 52 elected officials from serving because their term would be up in 2023 as well, which would leave they would leave a midterm vacancy on the board if they wanted to serve. Did I get that correct? Is that what I'm understanding?
Well, let me first say two things. One, this is the draft proposal that the county commissioners intend, as I understand it, to have a hearing related to that they will eventually adopt. So in this form as it currently is, it's not in its final form. I believe this language was what we had previously in our prior resolution. I don't know that we've ever run into this issue before, Ryan, and you may need to clarify this one for me. Have we run into this issue before in terms of person's position sort of terminating midterm?
No, we haven't. And if that was the case where they were not reelected or did not seek reelection, then we would just fill that position for the remainder of that term.
Yeah. So I don't think it would disqualify you, Councilwoman Duvall. I don't think that's the intention, unless the commissioners had a different approach. That's not how I read it, but I just wasn't sure whether we'd gone through that issue before. I didn't think that we had.
Yeah.
Yeah, I appreciate the comment. I would just say, I don't think the intent of that, and I appreciate you bringing it up because I don't think the intent of that is to discourage people from running for, for office. I think it was simply there in the event that if somebody had announced ahead of time that they had no intent to run, then we would want to consider someone else for that position.
To your point, James, we have had people leave midterm and we've had appointments until that term is filled. So that has been our normal course.
Ms. Duvall.
So I guess my concern again would be that, you don't want to say that you're running for office again, because then you have to file with the PDC within 2 weeks of having made that announcement. And since at the end of this year, I don't know if I'm going to run again. Maybe I will, maybe I won't. I don't. So it's hard to tell because a lot can change in a year. So I guess I just want somewhere, I would like it removed if that's not the intent. And just, I would suggest that it just lets the elected officials serve their term in office instead of it could potentially discourage them from wanting to apply to serve.
I think when we were talking about it so long ago, the idea is that, if your elected officials are going to apply to be a member of the Board of Health and knowing what the length of the term is for the Board of Health, and then knowing that they were already going to have a possibility or a known fact that their term for elected office was going to end, we don't want the Board of Health to continue going through the process of, applying, having people apply and vet. And the idea is that if you are someone who's an elected official and your term ends when you know that it will become sooner than what the board position would end, then you're not a good candidate, because you're going to potentially cause the board to have more action that is required, because then there's going to be a mid-year appointment, you're going to have to advertise. And so the idea was to try to make it as neat and clean as possible. If I'm recalling how we had these conversations before, is, you know, you really are trying to make it so that we're just not messing up all the alignments to what I think Ryan was talking about earlier, is that we've got these issues. And if we're trying to remove that situation of having multiple times throughout a year where potentially you're trying to get people advertising for health board positions and decrease turnover and the process. I think that's kind of what I recall the conversations that we had so long ago.
Ms. Duval.
So it could also be the other way around. In 2023, when my elected term is up, as well as council and buyers, it might not be up if we do decide to run again and retain our position as an elected official. So it's kind of it sounds like they're just the extra work of recruiting and interviewing another member is what's not wanting to be done.
Commissioner Lindy.
You know, one of the things that the commissioners that we left out of this ordinance was the length, well, not the length of the terms, but the staggering and the timing of the terms. And that was done because we really wanted to leave that to the Board of Health. And so, of course, we're going to have a hearing, as you know, within the next 2 weeks, but we really left that part up for deliberation for the Board of Health. So that might be a consideration when we get to that point of, when do we actually want these terms to run? That might be consideration at that time.
Well, I would share, I'm grateful that we're having a conversation. One of the things that we attempt to do when we have people join our board is to embrace the fact that as board members, they may come for specific reasons, whether they're elected officials or they're citizen representatives. But the reality is that they're embracing the role of ensuring the health and safety of people in our county. I would not want something that was positioned as a disincentive. Recognizing that may not have been the intent, but again, we want people to serve, and when they are serving, we want them to serve credibly and well. And so we wouldn't want to reduce that tenure simply because of the potential that someone may not run again.
Commissioner, Council Byers.
Yes, thank you. Councilman Duval, I thank you for bringing this up because I wondered about it myself and just hadn't asked the question. And if somebody does decide to run again, there's no guarantee that they will be elected again. So it leaves us in the same limbo position. The desire may be there. If they decide to run again, they may not be elected. So at what point is the decision made that, they need to be off the board?
Yeah. Any other comments or questions?
My final comment is that the 2 years that we dedicate to serving on this board, the first year is a big learning curve. So I feel very invested in this board. I make a lot of sacrifices at work to be here, and just because my term is up midterm, I just don't want to be discouraged or I'm not a good fit for the board because of my elected position status. And again, out of the 94 city and town elected officials, I'm concerned about the 52, that's over 55% of the elected officials that would not be a good fit.
I think, Nyla, to your point is that very well taken, that you are committed and there's nothing that precludes you or anyone else from then going and seeking a position of an at-large community member. And so I don't perceive this as being any way a deterrent. If your passion is to serve on this board and anyone is in an elected position and then they no longer become an elected position, there's certainly nothing that precludes that person from still wanting to serve and to applying for a different position.
If those positions are available. To Nyla's point, there is a learning curve the first year, and we all make the sacrifice of being here, but the fact that we're doing that should speak to our level of desire to be involved. So,
yep, appreciate that. Any other comments or questions? Commissioner Lindy.
Yeah, I would just say that I appreciate the dialogue and the feedback. One other thing, I think when these documents were sent over to, I can't remember if it was Mr. Elliott or to administration of the health, I think it was to Mr. Elliott, there was an article also in addition that was sent over. And this had to do with what Chelan Douglas County had done when they appointed members to their board under the new law. And it was reflective of what our intent is, what we're trying. So it'd be nice to see that that document or that article was also sent out to the members of the board, because I don't think they've received that.
My understanding was that was sent. If it wasn't, that wasn't by design. I thought that was part of the letter that came from the prosecutor's office. So
I didn't receive it in my packet, so I'm just not sure if others have received it.
If I may, Commissioner Anderson.
Yes.
I'd just like to share that Chelan Douglas is but one of any number of local health jurisdictions, and there's varying interpretations, and I would also say perhaps misinterpretations of what 1152 is. It's a very ambiguous bill, unfortunately, and allows for interpretations that are different in different jurisdictions. So while I recognize the interest in looking at why Yakima County may have made the decisions that they've made, there also are other organizations or other jurisdictions, I should say, thank you, that are interpreting it differently.
Okay. Dr. Cleary.
I know that in my email, I have received 4 documents, and one of them was from the Chelan Douglas. So it may have been there. You may have just not scrolled down far enough. In your letters, Mr. Elliott, I think you raised a concern that the proposed draft was in conflict with your interpretation of 1152. Is there anything that you feel is potentially illegal or in conflict with what the legislature passed in 1152?
Well, I think the reason why I want to make sure you saw my email was so that each one of you could see where I identified my area of disagreement. There are a couple areas where I made suggestions, though not required by law. I made suggestions to the county commissioners in terms of how to deal with it. But with regard to the specific piece related to the selection, I wanted you all to see my email so that you could not only refer to what I was identifying, refer to the rules so you could see it. I think I laid it out pretty clearly. I mean, I can take a minute to sort of lay it out for you if you want, but it's an area I have a disagreement, and I identified it, and we are where we are.
Thank you. Any further comments or questions? Thank you very much. A very good discussion. We will now move on to item B, which is
could we give Mr. Elliott just a minute to go over things orally? I'm sorry, I thought he was going to do that.
Oh, I'm sorry, Dr. Atterbury. I was just identifying it. Essentially, what I laid out in my email was, in looking at the rules, there's sort of a breakdown in terms of the pieces that are there. The rules that you have, 24690, lay out 3 different functions related to this for boards of health that deal with our situation. And essentially there's recruitment, that's one piece. You've got selection, that's a second piece. And you've got appointment, that's a third piece. Each one of the rules in 24690 kind of lay that out, Dr. Atterbury. The first one deals with recruitment, which would be WAC 24690-020. And if you read through it, the section there describes the recruitment piece is related to the Board of Health. It's the only organization identified there. The second issue then is with regard to selection. That's found in 24690-025. The selection of the board member, if you read through this, only ever identifies the local Board of Health as the one making the selection of that person. And then the third portion is the role that the county commissioners play in this, which is 24690-030. It identifies, the only section that identifies what their role is approval and appointment. And as I pointed out in my email, my position is that selection actually is for this Board of Health. And if you read through it, I essentially said the Board of Health would select the applicant that would then be referred to the Board of County Commissioners, and their role would be in approving and appointing that person. So the area where we have disagreement is, I think if you're putting the two things together, the county commissioners have identified sort of two steps that I'm not sure I'm in agreement with. So that's the reason for my email.
Okay.
Does that make sense, Dr. Atterbury?
It does. Yeah. Thank you.
Okay. Any other questions? Councilwoman Duvall.
Yeah, so my other, I guess, concern with this is on number 2 of chapter 6.04, part D. It says even the proposed election process of an elected official after they've submitted their letter of qualification and their application, Part D says the Board of County Commissioners may interview the applicants. I guess I don't know why they wouldn't want, why they don't interview them. Maybe not all of them, but wouldn't you want to interview the applicants so that you select the best one?
Commissioner Lindy.
And I guess I would say that, you know, what if we have a circumstance, for example, where only 2 people apply for 2 positions? You know, I think most of the time we would want to know as much as we could about a candidate to make an informed decision.
Okay.
Does that answer your question?
Yes. Yeah.
Thank you. All right. Any further comments or questions? Thank you, Mr. Elliott, for your explanation.
Thank you.
If there's no further discussion on this, we will move on to the next item, which is the overdose deaths in Washington, and Commissioner McKinney.
Yes, and I know, Melissa, you're thankfully going to be able to, it sounds like maybe kind of expand on this, but you know, the Department of Health has come out and so has the CDC, and you know, our worst fears about the shutdowns from pandemic-related shutdowns, mental health. Obviously, a lot of people expanded to drug use, and it's also, unfortunately, our southern border being so porous and open is bringing in incredible amounts of deadly fentanyl, and you know, we're getting to a point where now our Department of Health, I think you saw the article, is recommending that that we as residents start potentially carrying around the drugs, you know, Narcan or similar, to try to, you know, be able to help someone who is experiencing an overdose. And it's kind of tragically gotten to the point where it's similar, I think, to how we now view AEDs, you know, where, you know, there's a life-saving device in public spaces. And I just thought it would be good for us as a board to discuss this. I think Lillian will have some relevancy, because I think that really, you know, when I was growing up, you know, we had DARE, and you had a real, you know, don't do drugs or don't drive drunk. And we all saw the vehicles that were crashed, and the state troopers would come and show you. And you know, as young kids, we all think we're invincible, and you would look at that and say, well, that will never happen to me. And you can see those dangers coming. But the danger in these drugs, the fentanyl, is that they are in pill form, and they look just like something that you might think is a safe thing. And we've heard and seen just tragic events where young adults even were thinking that they were taking something, albeit illegal. They thought it was something that was safe, and it turned out to be laced with fentanyl, and they died. And even those people who try to resuscitate them end up significantly impaired and having to be hospitalized, and sometimes you know, potentially having a threat of their life being taken as well. it's so crazy. A child could go to a high school party and take a pill that they thought was Xanax, thinking they know what Xanax is, and it isn't Xanax. And I think you've got a 40% chance of rolling the dice and having that have a lethal dose of fentanyl now. So, as a mother to a teenage daughter, it scares the heck out of me. And I just really hope that I think that we can embrace this and maybe come to some solutions as a local health board of how we want to help our community educate our children, our young adults, and how are we going to address this really significant issue.
Yes, I'm glad you brought this up and put this on the agenda. It's something that I think about all the time as well. It's very important to me. One thing that we have been distributing naloxone and Narcan at our needle exchange since 2017. We have, I can tell you, let me look really quick. I'll have to pull it up. I'm sorry, I lost the page that I was on. But we, actually here it is. The reporting has kind of diminished since COVID. So they weren't reporting for third and fourth quarter of 2021. But in the first 2 quarters, we had 53 cumulative 79 overdose reversals in that first 2 quarters last year from just naloxone alone that we distributed through our syringe program, which is amazing. I mean, these are other drug using population that administered it to people that they were around, that they were witnessing an overdose on. Washington State also noticed that this is a huge problem, and they wrote a standing order for anybody to be able to go into a pharmacy that carries naloxone. You can just take in that standing order. You don't have to have a prescription, and you can get naloxone, and it's covered by Medicaid. I'm sure it's covered by most insurances, but that's something that anyone in the community can do. So if you're worried about your child or another family member or a friend, anyone can go in and get that. That's something that Lily and I are working on messaging, because this is something that's been going on for a couple of years, but I just don't know that the community really knows that this service is out there and that anyone can get this now. So definitely something that we're wanting to push. I think that, how do we talk to these young kids? Because that's, it is really traumatizing to see a death certificate come across your desk, and it's a 17-year-old, and you think, this kid probably had no idea what he was taking. It's very tragic. And I think that we do need to find a way to message to those younger kids on how to, be aware and be cautious on what they're doing. And we also distribute fentanyl strips at our syringe service program as well, to try to prevent, so they can test their substance to ensure that it doesn't have fentanyl, or that it does. And we've done surveys, and some of them change their behavior based on it. Some of them have chosen to, they're still going to use the drug, but they make sure that somebody's with them that has Narcan in case they were to overdose. But it has, I believe it's helped save some lives out there from the fentanyl strips we've distributed.
Yeah, my concern is really a broad concern, but really it's focused towards our youth. And that is the part. I think the DEA did a randomized test of seized narcotics across the nation. And I think they found that over 40% of them had lethal doses of fentanyl in them. So this is really Russian roulette to, again, we're talking about teenagers and young adults who think that they're just going to be doing something at a party. It's a little different than taking a Rainier or a Miller Lite. This is a much graver potential outcome. And so I do think the outreach within our middle school, high school community, it's not, the peer pressure might be there to do something, but it really isn't what you think it is, or the high chance that it isn't. And I don't know if, maybe we can do proactive outreach and try to get some local youth who have had a negative experience, who would be able to go and help speak to the students and tell them that they thought they were just taking this pill, and it ended up causing, almost a life, they almost lost their life. I mean, I remember the impact of having that crushed car and having someone come, speak to us because they were involved in an accident because they drove drunk at a party, that kind of thing. It has a big impact. So I think that anything we can do to use our own local youth to talk to them about, really, it is Russian roulette. It's just, it's scary.
Ms. Duval, you had your hand up a few minutes ago. Did you have a comment?
Well, being that I work in the school district, I do know that the ESD 105 does have district support. There are some school districts that have community prevention specialists that focus on drug abuse and working with high risk students. And I would just encourage, to reach out to them to see what they're doing. I know that they do a lot of community events. They have a dedicated staff member in high risk school districts, but it's not everywhere. And maybe it needs to be. And I know that it's a very, very good approach.
Yes, thank you, Councilwoman Duval. I just wanted to quickly comment on that. Those are some conversations that we started exploring with those groups. They're called, I can't remember what it stands for, but they're CWPIs there, and Highland School District, White Swan School District, Yakima Sunnyside School District, and Wapato School District. So those are conversations that we're planning to initiate to see how we can partner in that way as well.
I would just say, with all due respect, I think that every youth is at risk, no matter where they are to this. And I think that it would be important that every single middle school and high school in our community had this conversation going.
Yes, absolutely. And just to clarify, those are the locations that have that CWPI coordinator, but absolutely, it would be a countywide effort. Thank you.
Council Byers.
Yes, thank you. When I first came on the council, I'll go back to that a little over 2 years ago. Someone from the Spokane, in Spokane, from a federal government office, I think it was the Attorney General's office, said there were some educational materials that were very well done, excellently done, could be used at every level in the community, and he was going to come and present that to the city of Yakima. And then COVID hit, and all communication about that stopped, even though there was a growing concern about the increased drug use with COVID. Unfortunately, in the meantime, he retired. I have not been able to find out since then who we should talk to about it, but I know that there are, some educational materials that I understand are very well done, available to the community, because he wanted to bring them all in, and they're available to any community. So if I can locate at least the current contact person, I'll pass the information on.
Thank you. Any further comments or questions?
I would mention that, the times really have changed. When we write narcotic scripts nowadays, we're routinely giving out Narcan scripts with that. That's something that was different than 5 years ago or 10 years ago. It is a absolute travesty that we're not prosecuting some of these drug crimes, and our cavalier attitudes toward the use of drugs is really leading to the outcomes that we're seeing. So we should be messaging an anti-drug message across the board to every citizen of our county, and we should be doing something to prosecute these cartels that are willingly killing thousands of our youth, and with zero regard for anything in terms of the value of life. So I can't send that message enough to my own children, to children I interact with, to anybody, because I think that there's just a societal attitude that, oh, drugs aren't that bad now. Marijuana is, almost encouraged, and it's absurd. The message is absurd. The message we're sending is absurd, and we should do something as a Board of Health to try and alter that message, to try and reinforce the idea of good, healthy choices. We talk about food supply, which is important, but not taking fentanyl is more important. That's a huge message that we need to get across, because you can't tell the difference. And I've seen the counterfeit tablets. You cannot tell the difference. I'm a physician. I'm around these things all the time. I cannot tell the difference. So nobody using drugs is going to know the difference until they're dead, in which case they'd say, oh, I got the bad dose. I got the hot dose. It's a terrible travesty. And so I would just encourage all of us to think about ways where we can message stronger, better, more reliable. And it's not going to help coming from, 50-year-old Dr. Atterbury. It's going to help coming from 18-year-olds, 14-year-olds, 16-year-olds, because I already know I don't take fentanyl. However, dead 14-year-olds just beyond a loss to a community. I mean, can we imagine what those people could have done with their lives? Think about that.
Lillian, is it possible for us to pursue then, you might be able to follow up with us and see if there outreach to ESD 105, or just see if there's, you know, a gap or how we can partner and help advance that message into the school systems locally?
Commissioner McKinney, if you don't mind, I'm so sorry. I think we have some additional comments in terms of the work we're doing, but I would ask that we could recognize, I think Dr. Cleary's had his hand up for a while, and
Oh, I'm sorry.
I'd ask that the staff wait until the directors have, or rather the board.
Dr. Cleary.
Thank you so much.
Thank you. So if you go on the King County public health site, they have a huge amount of packaged information that's available as PDFs. They also give school education programs that are packaged. They have a very strong push of educating not only the students, but also the parents as well, because any parent, any coach, any organization leader that involves teenagers needs to know how to use Narcan and have Narcan available. It's a sad thing, but your child may get one of these drugs without even being aware. If it's in powdered form, fentanyl is incredibly potent. A tiny amount can put somebody down, and the pills again are underestimated in their strength. And so it's easy for a child to come home having been given something, and you need to be able to use Narcan. Narcan is incredibly easy. It's a simple, non-invasive, just squirt in the nose, and it will save lives. So I think you should look at what other public health departments have before we go reinventing the wheel, because it's definitely out there, and it needs to be introduced into schools as soon as possible. It's great that the number of teenagers using drugs has markedly dropped in the last 10 years, particularly in the last couple of years. But the fatality rate has doubled just in the last 2 years.
Yeah. Commissioner Lindy.
Yes, thank you. I appreciate all the comments, and I appreciate this issue being brought forward. This really is a tragedy and a travesty. And one of the things that I have noticed, between my time at the hospital and now on the Board of Commissioners, just that really drug abuse really is our number one issue, I believe, in this county. I've seen it happen to patients in the hospitals. I've seen it, the impact it has on our prisons, the high amount of people that are incarcerated right now that are there due to a drug-related issue. The people that are, that make up our homeless population, what a big factor drug abuse is among that group, among our citizenry. And I appreciate also Dr. Atterbury's comment about, we've really got to universally get away from the idea of glamorizing its use. I really would encourage us as a health board and the health district to really take a good look at that and how we send that message to particularly our kids and young adults, that just the dangers of drugs in all their forms. I mean, obviously the fentanyl is our number one concern right now, just because it is so deadly. But so many of these drugs are the starting place for some of these people. They don't necessarily always start with fentanyl. They start somewhere else, and so it would be good to take a comprehensive look at that message. And I think Dr. Atterbury's point is well taken, is that they may not care so much about what 50 and 60-year-old people say, but maybe if we have teenagers and other young adults that are helping give this message, that's a good approach. Thank you.
Thank you, Commissioner. Any further comments or questions?
Lillian, I know you were going to respond to Commissioner McKinney, and I certainly would like to wait for you to do so.
Sure. Yeah. So absolutely. That's we were already working closely with these CWPIs before COVID with youth marijuana prevention. So it is something that we need to reconnect essentially with those groups. So we're happy to do so with this topic specifically, and give an update later on.
Thank you, Lillian. I appreciate it, because to Dr. Cleary's comment, we've seen youth deaths related to drug overdoses double in the last 2 years. And that's because of the pandemic shutdown. And this is exactly what we were concerned about. And so we just talked earlier about the numbers. COVID didn't impact our children in the way it did people who had health issues and who are older, but we certainly put them in a really terrible spot now, because now they've turned to other places because of the depression and the solitude and the loss of hope and disconnect. So, we've got to now deal with the repercussions. And so it's really important that we focus on our youth because they are our future.
I'd like to respond to something that Commissioner McKinney said, because I think it's really sparked something of interest to me. We've been working on this issue of naloxone again, as Melissa mentioned, since 2017. We pushed very hard to the state, and we also pushed working with the University of Washington to find a way to distribute naloxone. We've also worked very hard to support education to the family members of people who are using drugs. Commissioner McKinney's bringing up a really interesting point, which is the idea, you had mentioned defibrillators, but I'm actually realizing now something that I hadn't thought about, which is the idea that sometimes if you have a friend of your children who is allergic to bees, you may actually have a kit that allows if someone has anaphylactic shock. So one of the things that we've been discussing in the last few months is the idea of creating a campaign where we can educate about the fact that things are readily available, but people may not recognize that, one, they are available, as was said, a standing order, as Dr. Bard indicated, to get this essentially for free, or also the need. I think there are often times where people who have children will say, well, my children are not into that, or I don't have a family member who is a drug user. The reality is, though, you're bringing up the idea of being prepared for an unfortunate and perhaps not planned event that leads to tragedy. And I will share with you, one of the things that's difficult about fentanyl, as many of you have mentioned, is that it doesn't look dangerous. It may look like a simple pill. And that pill is very different than the dangers of a car accident, or the dangers of the realities and complications of intravenous drug use. It looks very simplistic. It's simple. You put it in your mouth and literally it can kill you. So we're also dealing with another issue, which I want to be very fair about. Is my understanding is that fentanyl is being manufactured specifically. It's an artificial manufacture of a drug, and it's being done in places like China, and it's coming through trade routes, and it's coming through Canada to us. So we are really in a crisis, and it's not just COVID, it's a crisis of people really profiting from death. And so the idea of positioning around a campaign to communicate this, I think, has value. The issue, though, that's separate to that is this issue of naloxone distribution. And I think that that has a tremendous impact in a community like ours. So I would like to embrace that. It's something that we have been doing, but the idea of really being very out in the open with people about the realities of being prepared for something that, frankly, many people don't want to talk about, which is the potential for their children or people that they know to use drugs, I think is very real. And I would also share that there are young people, I suppose people of any age, who think, well, I'll just try this once. And obviously it can become a dramatic impact on their lives, on their families' lives. As you've shared, it's a family tragedy. It's a community tragedy. So we'd like to look at that and come back to you with our suggestions, because again, I would very much like to work on a communication platform and support for our clinics around the availability of Narcan, because it is widely available. But it doesn't change the fact that it can be misunderstood by people. And it also requires them to go to the pharmacy to get the prescription filled. And so we have to really motivate them to do that. Also, I will share that we have been working, and again, our team has been working on supporting clinics in receiving medication so that it's available. Melissa, you can do a better job of explaining that if you will, but I think it's necessary to explain that we have been trying to take a partnered approach to this.
Yeah, so the Department of
you said, I just want is what I was hoping for, because I will say that you read the horror stories and nobody wants to think it'd be their child, but I would much rather have it in my house, knowing that my child or any other child visiting, because I've read about parents who woke up and their 14-year-old came home and decided to do this in their room, and they woke up and their 14-year-old didn't wake up. Yeah. And you don't want to think that it's going to happen, but just like you mentioned, I honestly, you just don't know. And I would much rather be able to say, you screwed up, but we saved your life. Now we're going to talk about don't do that again. I'd want my child to be alive.
Lillian?
Oh, I'm sorry, Melissa, were you going
Oh, I'm
to?
sorry,
I'm
Melissa.
sorry.
Yeah, I was just gonna speak on what Andre was saying about the Department of Health. They have a program where they can distribute free naloxone to organizations such as law enforcement, correctional facilities, EMS. Let's see, who else is on here? Local health jurisdictions, people who deal with homeless and housing. So there's a program through the state, and anyone that calls me, then that's who we refer them to, so they can get set up. And then, of course, for the community is the local pharmacies. And I'll just add that it's not always just the fentanyl. I mean, some of these kids, this fentanyl is being put into numerous drugs, and so a kid might think he's taking, his friend says it's Tylenol, and it could be fentanyl. Like these kids just don't know, and so it's not a kid going out. I think the messaging needs to be like Dr. Atterbury said. It's all drugs, because any one of them can be laced with this fentanyl and kill any one of these kids.
And if I may add just quickly, vaping as well. The liquids that people receive have chemicals in them that can be very dangerous to them.
Mm-hmm.
Yes, Ms. Duval, we do distribute through the needle exchange program as well.
And Melissa, is that available to local health clinics that wanted to take part in it as well for physician offices? And if so, can we openly distribute it to patients without any paperwork trail, or is it what it's required?
I think physicians are being encouraged to write the prescriptions, and then it's covered by Medicaid and I'm sure insurance as well. Mm-hmm. But we would never turn somebody down. So if somebody came out to our syringe program and asked for Narcan, even if they're not a drug user, but maybe they have a family member, we always will give out Narcan to any of those individuals.
Thank you. Council Myers.
Yes, thank you. I think that the campaign to educate the community and make available the Narcan treatment is very important, because this problem has become overwhelming, even in our community, let alone other places. The other side of that is, if that's all we do, then there can be an attitude on the part of users, well, somebody's going to help me anyway. I'll have a friend come with me, as Narcan with me, so I can be okay to try what I want to try. We really still need to continue to, from a very young age, hammer home the educational piece of how dangerous drugs of any kind are. And, they look at it and like you say, it's just something visual. It's easy. You pop it in your mouth and they have no idea what's in it. And to the point of that, all of this is for the most part manufactured out of our country in labs in other countries where they have no quality control, whether it's intentional or unintentional, it does not make any difference. We have no idea the level of fentanyl in any one of those things that can be hidden in. And it can be just, a little something, or it can be enough to kill them in an instant. So just the educational piece of drugs as a whole, not just about the fentanyl or what can be hidden in, but drugs as a whole, to deter the beginning and the use of drug use in the lives of young people. They have to go hand in hand, not only the prevention of death in terms of using Narcan, but the prevention or the preservation of life and healthy life over the long term, by educating from very young ages how dangerous drugs are.
Right.
Commissioner Anderson, I was hoping to recognize and the board for having a discussion around a really difficult topic. We often in public health are dealing with these very difficult societal issues that are complex in nature and also often very painful to discuss. So I just want to recognize and share my personal appreciation to the board for discussing a difficult topic where we feel very strongly nonetheless that we have to be involved. And I want to thank you for your consideration and support of the fact that we are really trying to protect our community, even in these difficult circumstances where we're dealing with painful issues.
Thank you. Any further comments or questions? If not, I will entertain a motion to adjourn.
Move to adjourn to the next scheduled special Board of Health meeting, which is May the 12th, 2022 at 5:30.
Second.
Okay.
Second. Is there any further discussion? Hearing none, all those in favor say aye.
Aye.
Yes.
All those opposed? we are adjourned. Thank you all very much. This was a
Thank
great
you, everyone.
interaction. Thank you.
Thank you. Have a wonderful day.